Hello, I am Dr. Elena Parker, neurologist specializing in cognitive health and aging, and I am here to tell you about one vitamin the brain needs after age 60 that almost no one consumes enough of. Have you ever reached for a word and it vanished from your mind? Or walked into the kitchen and forgotten why you went there? Recent studies suggest that roughly 43% of older adults may have low or suboptimal levels of vitamin B12 without knowing it. Picture your brain as a high-performance engine and vitamin B12 as a rare but essential lubricant. When it is missing, the gears grind, attention blurs, and a fog settles over simple tasks. In the next 10 minutes, I will explain why this happens with aging, what common medicines can block absorption, how to ask your doctor for the exact blood test you need, and the practical supplementation approaches that often restore clarity. Listen closely, because if you or someone you care for recognizes 2 or 3 signs I list, a straightforward test and guided treatment can change daily life. The sound of conversation becomes clearer when the fog lifts, and many patients describe the first breath of relief as almost audible. Preste atenção to what follows. You will hear specific numbers to ask for in the lab report and 2 real cases that show how detectable deficiency was corrected and cognition improved in weeks. Now let us look at the size of the problem. Population surveys and clinic series show that deficiency of vitamin B12 is common in people over 60 because absorption changes with age. The stomach makes less acid and less of a protein called intrinsic factor, both required to liberate and carry B12 into the bloodstream. That is why even eating B12-rich foods like liver, shellfish, eggs, and dairy may not prevent deficiency in older adults. In practice, I see patients who eat a balanced diet yet have biochemical deficiency because the problem is one of absorption, not intake. Metformin for diabetes and proton pump inhibitors for reflux reduce B12 absorption, and long-term use markedly increases risk. Think of your gut as a small factory that needs heat and a special transporter to pack the vitamin for delivery. Lose the heat and the transporter, and the vitamin piles up unused in the warehouse. Clinically, this matters because B12 is essential for myelin and for the production of neurotransmitters that control memory and mood. Low levels are associated with slower processing speed, balance problems, numbness in the hands or feet, and mood changes that mimic depression or early dementia. Some labs and guidelines differ on cutoffs, but a pragmatic approach I use is to consider values under 400 pg per ml as possibly insufficient in symptomatic patients, and to correlate with methylmalonic acid when results are borderline. The test to request is serum vitamin B12 and, if available, methylmalonic acid or homocysteine to confirm functional deficiency. Now I want to share a case so you can see how this plays out in a real-life clinic. Robert came to my office at 72 with his daughter Maria. He smelled faintly of coffee, and his sweater had a small patch where he had absent-mindedly spilled cream. He described fogginess and dropping small objects. I asked him to describe a typical morning. He said, "I wake up, I make coffee, then I look at the kettle and cannot remember if I turned it off." I said, "How long has this been happening?" He replied, "About 6 months. It is worse some days." I touched the back of his hand, and he flinched at a light tap, reporting tingling in his fingertips. I ordered labs. His serum B12 was 180 pg per ml, and his methylmalonic acid was elevated. He had been on metformin for type 2 diabetes for 12 years and used omeprazole intermittently. After discussing options, we started oral methylcobalamin supplementation under supervision and arranged for follow-up. At 4 weeks, his daughter Maria told me she could hear a change in his voice on the phone and that he laughed more. At 8 weeks, Robert reported, "I feel sharper. I can remember names again." His gait steadied and the tingling eased. This case shows sensory clues, smell of coffee in the room, the tactile exam, and a short dialogue that captures both worry and relief. Now let us list practical signs you should not ignore. If you notice frequent forgetfulness, like missing appointments or struggling to follow a recipe, persistent fatigue that does not improve with sleep, numbness or burning in the hands or feet that changes how a shirt feels against the skin, unexplained mood shifts or depression, or balance problems such as catching yourself while walking on a carpet, these are all red flags. Imagine the taste of a salty cracker that seems dulled, or the way a sweater's fabric feels suddenly foreign. These are subtle sensory shifts that patients describe when myelin is affected. If you recognize 2 or more of these signs, ask your clinician for testing. At this point, I invite you to write in the comments which symptom resonates most with you. Write "my case," and a brief sentence like "my case, forgetting names," or "my case, tingling in feet," and I will read and, when possible, respond with practical suggestions and topics for future videos. Sharing helps others see that these problems are common and treatable. Before we go to the second case, I want to be clear about diet and medications. Foods richest in B12 include beef liver, clams, oysters, salmon, and dairy. For older adults who avoid animal products or have absorption issues, reliance on food alone is often insufficient. Groups at higher risk include people over 60, those on long-term metformin, those on acid-reducing medications such as proton pump inhibitors or H2 blockers, people who have had gastric surgery, and strict vegans. Medications that deserve attention include metformin, omeprazole, and even long-term histamine blocker therapy. If you are taking these medications, ask your prescriber about periodic B12 monitoring. Now, a second case to illustrate treatment options and choices. Helen is 68. She works part-time at a library where the smell of old paper and lemon oil polish filled the reading room. She came with her son Carlos and her neighbor Anita, who had noticed her turning pages slowly and misplacing her reading glasses. Helen described a low humming noise in her ears at night and nights when sleep was shallow. I asked, "Helen, what do you eat for breakfast?" She replied, "I usually have coffee and a plain bagel." I asked, "Any stomach surgery?" She said no. I placed my hand lightly on her forearm and she described a brief electric twinge when I tapped the nail bed. Her lab showed B12 at 230 pg per ml with a mildly elevated homocysteine. We discussed supplementation options. I explained there are 2 commonly available forms, cyanocobalamin and methylcobalamin. For older adults with cognitive concerns, methylcobalamin often provides better direct availability in the nervous system. She asked, "Does that mean injections?" I answered, "Not always. Many patients start with high-dose oral methylcobalamin or sublingual forms if their gut can absorb. If there is severe deficiency or neuropathy, injections are sometimes used briefly to restore levels quickly under medical supervision." Nurse Laura coordinated the plan and we scheduled follow-up. Within 6 weeks, Helen reported clearer reading, less humming at night, and she smiled when she said, "I can sit through a chapter again." Her son Carlos hugged her and told Anita it felt like his mother came back to him. This case shows a dialogue of questions and reassurance and names of people involved who observed real change. Treatment notes I emphasize are: request serum B12 and methylmalonic acid or homocysteine if possible, discuss medication review, consider methylcobalamin as the preferred form for neurologic support, and always manage dosing and route with a clinician. Typical empirical regimens vary, but many clinicians use daily oral methylcobalamin in higher doses for weeks and then maintenance dosing, or short-course intramuscular B12 in severe cases. Monitoring should include symptoms and repeat labs. Behavior and lifestyle remain crucial. Engage in regular aerobic activity, which increases cerebral blood flow. Maintain a protein-rich breakfast where safe. Ensure social interaction and mental stimulation to support cognitive reserve. Simple sensory habits help too. Notice the smell of fresh fruit in the morning, the texture of your cup as you hold it, the feeling of sunlight on your wrist. These small sensory anchors help the brain rebuild associations. Before we close, let me summarize. If you have 2 or more warning signs, request serum B12 and ask for methylmalonic acid if the result is borderline. Mention to your clinician that you are concerned about absorption and medication interactions, such as metformin and proton pump inhibitors. Consider methylcobalamin as an option for neurologic support, and pursue supplementation under medical guidance. Real patients like Robert and Helen often show measurable improvement in weeks when deficiency is identified and treated. If this video helped, share it with family or friends who are over 60 and might be living with silent deficiency. Subscribe to learn more practical steps to protect cognition, and write your experience in the comments starting with "my case:" so we can build a helpful dialogue. Thank you for caring enough to listen. Take action today. Ask the question at your next appointment. And remember, a small test can protect a lifetime of memories. Care for your brain today so it can care for you tomorrow.